Please note that as an attendee, you are in listen-only mode and will only be able to view your name. If you have questions, please send them to the presenter and me, I'm the host, by using the Q&A panel. The button to open the panel is usually located on the upper right side of your monitor. So please use the Q&A panel to send any questions you may have as you think of them, and the presenter will answer questions at the end of the presentation. And we may also address some of those questions at our break. Our audio is being broadcast through the internet to your computer. You must have speakers attached to your computer, of course, and have the correct software and the volume on. If you have any difficulty with your computer audio, there are a few options to try on screen right now, and we'll also post these in the chat box for you. But if you continue to experience a loss of audio or poor audio through your computer, you can also join the webinar and use the call-in feature. And actually it reads, I will call in option on your WebEx screen. And of course, you must be connected to the audio portion of the presentation and view it on screen as well to receive a certificate of attendance. The recording and materials used in today's presentation will be available on the FADA website within 5 business days. To access the recording, you can go to www.fada.org. Also, a PDF version of this PowerPoint presentation will be emailed to the participants within 5 business days. Approximately 1 to 2 continuing education credits are available for participating in today's webinar for persons licensed through the Board of Nursing, the Board of Clinical Social Work, Marriage and Family Therapy, and Mental Health Counseling, and also for persons credentialed through the Florida Certification Board. At the event's conclusion, the web browser will direct participants to an evaluation form on the FADA website. If you would like to receive continuing education credits or a certificate of attendance for this event, you must complete the evaluation. Be sure to include any Florida license number, if applicable, for reporting to CE Broker, along with the prefix for your license number. Certificates of attendance will be delivered to your email address within 5 business days. Do keep in mind that WebEx monitors arrival and departure of attendees and provides a report upon completion of the event. This attendance log and the evaluation forms are used to validate the provision of contact hours or the certificates of attendance. We are not permitted to provide contact hours or a certificate of attendance if you do not attend the entire webinar. And we are not permitted to provide partial credit. And Dr. Pomm will be covering the learner objectives for today. And let's go ahead and introduce our presenter. Raymond M. Pomm, MD, is Vice President of Medical Services at River Region Human Services and Medical Director for Gateway Services. Board certified in psychiatry, addiction psychiatry, and addiction medicine, he has been a leader in the addiction field as it relates to the evaluation and treatment of co-occurring disorders and management of impaired professionals. Dr. Pomm is a certified medical review officer, served on the Governor's Commission on Mental Health and Substance Abuse, and has been an expert consultant to the Florida Board of Bar Examiners. Dr. Pomm has practiced in the field of psychiatry and addiction for 37 years and has written numerous publications on issues surrounding addiction and urine testing. He has received multiple awards, including the Marie Award from the American Association for the Treatment of Opioid Dependence and the 2007 Annual Medical Leadership Award from the Florida Society of Addiction Medicine. A graduate of Meharry Medical College, Dr. Pomm completed a residency training program in psychiatry at Penn State University. And it's my pleasure to have Dr. Pomm join us today. And Dr. Pomm, I'm going to go ahead and switch over to your presentation, and then I'll turn control of the presentation over to you.
Thank you very much, Leanne. Good morning, everyone. Hope the weather where you are is as wonderful as it is here. I could deal with this weather every day. We have a lot of material to cover today. I do want to start with a little bit of a disclaimer, and that is you're going to hear about Premier Biotech as a laboratory. I want to let you know I have no financial involvement with them at all. I actually do not use them as a laboratory at all. They have volunteered services, and they have innovated new testing that I think is extremely important for you all to know about. Now, let me go ahead and, oops, I'm not getting a response on my.
That's fine, Dr. Pomm, and do remember to click inside of the navigation window and then use your page up and page down keys to progress.
I forgot to click inside. Sorry about that. Okay. The objectives for today I'm going to read. 1, participants will understand the full impact of current opioid epidemic upon the treatment field as well as directly upon individuals treated. 2, participants will become familiar with the most common drugs of abuse, their pharmacology, as well as their interaction with each other. 3, participants will become familiar with the various types of drug testing available, including understanding their benefits and pitfalls. And 4, participants will develop a knowledge base that will enhance their ability to utilize drug testing as part of their therapeutic approach to the treatment of individuals with substance use disorders. Now, one thing I want to start with is this. First of all, there are a lot of slides here. I'm not going to go over all of them. They're for your resource and reference later. However, one point I want to make as we proceed through this is to help you understand how we got here and the difference between what a lot of people have been talking about, that is prescription opioid epidemic, and the present epidemic. Yes, an extension of it, but it's a little different because the present epidemic is what's killing people today. We need to understand the past and have our eyes open in the present. So let's start with some basics. Some of what I'm going to talk about is certainly going to be review for a lot of people and maybe new for some. The difference between the terminology of opioids and opiates. Opiates have typically been known to be natural substances derived from opium, like morphine, codeine, well, thebaine, as well as then we get into synthetic opioids, modifications of naturally occurring opiates, heroin from morphine, buprenorphine, oxycodone, and then synthetic opioids, which fully synthetic compounds, methadone and fentanyl. So where opiates used to be called the natural substances and opioids used to be the synthetic and semi-synthetic, now what we're dealing with is one term, opioids, for both the naturally occurring as well as the semi-synthetic and the synthetic opioids. Whoops, I keep pushing the wrong button. Let's get into a little bit of history to understand where we came from and how we got here. Actually, in the Civil War, there was the introduction of the hypodermic needle and morphine as analgesia. In 1914, the Harrison Act was enacted, a prohibition on prescription of narcotics to individuals with addiction. The Harrison Act actually was the imposition of taxing of opium and cocaine. It regulated sale and distribution. And that was interpreted by the courts as now requiring doctors to write prescriptions for these medications, especially opiates and cocaine. However, in order to write the prescriptions, they could only write prescriptions for a disease. And at that time, addiction was not a disease, was not considered a disease. So doctors backed off of this, and it became the beginning of quite a problem at many levels, even though the intention was, they say, not financial, but it certainly ended up being partly financial and certainly regulatory. Many physicians were prosecuted because of fears of opioid prescribing. There was increased drug trafficking and crime associated with opiates, especially heroin and cocaine. And in 1974, the first methadone maintenance program was established for opioid addiction. Just an FYI, if this was interactive, I would sort of throw the question out, but it isn't, so I have to give you the answer. The question is, when was methadone first developed and by whom? It was actually developed by the Germans in 1937, and it was used on the combat field during World War II. It wasn't until the 1960s that we began looking at it for the treatment of opiate addiction. And of course, as I said, 1974, the first methadone maintenance program was established. Then in 2000, the DATA 2000 office-based treatment of opioid dependence was established. This was the beginning of the use of buprenorphine, and I'm going to explain all this as we move along in this presentation. I didn't even realize this, even though I was alive then, a little younger. In 1971, President Richard Nixon officially declared a war on drugs. That was the first declaration of a war on drugs. And in 1973, he created the DEA to coordinate the efforts of all other agencies. In 1984, Nancy Reagan launched her Just Say No campaign. That didn't work. Back in the DSM-4 days, we used to have the diagnosis of substance abuse. That was taken away from us in DSM-5, and I miss it sorely, because Just Say No might have worked for those that had an abuse diagnosis, but certainly once they cross that wall into dependence, saying no doesn't work because now the drug is controlling the individual. In 1989, President George H.W. Bush presented a national drug control strategy that included the largest budget increase in U.S. history. Unfortunately, even though there were large seizures of drugs and many individuals were imprisoned, we have continued to see an increase in drug use, which we are certainly experiencing today. Now for the beginning of really the problem as we are looking at in recent years and how it's developed from this point. In 1995, Purdue Pharma developed OxyContin. They actually marketed it in such a way that they were saying, hey, this really isn't abusive and is very safe to give for pain conditions. It was a really, the marketing campaign was sad, to say the least. And a lot of doctors believed what they heard, and they began prescribing this drug in quantities, in huge quantities. For those of you who don't understand OxyContin, I'll just take a brief second to say that OxyContin was actually a formulation of an extended-release oxycodone. Oxycodone is a powerful pill form of opiate, and where a typical dose of oxycodone might be anywhere between 5, 15, or 30 milligrams up to 2-3 times a day, they would put the entire amount in one pill because it's extended release. So it might be 20 milligrams, 40 milligrams, 60 milligrams, or 80 milligrams. Well, what addicts did was they crushed it. And whether they snorted it, took it by mouth, or shot it IV, they would get the entire bolus of oxycodone at one time, and people died because of that. This was actually really the beginning of prescription drug abuse. Eventually, they reformulated OxyContin into non-crushable form, but really, it was too late. Pill mills were going full throttle. Now, at that time, JCO, the Joint Commission on Accreditation of Hospital Organizations, were pushing very hard to treat pain and treat pain as a fifth vital sign. They did this without educating the physicians or the populace. and they established what we have come to know as the smiley faces. No one was to leave the hospital, a doctor's office, or the emergency department without achieving a smiley face. This was a significant step towards the overprescribing of pain medications, opiates. It was an unrealistic expectation and something we're having to reevaluate now. For those of you that have been keeping up with the news, they're now talking about establishing legislation where there'll be more physician education, a limitation on opiate prescribing. Well, my response to that is, yay. 20 years a little late, better late than never, but as you'll see, it won't actually impact the thing that is killing people today, which we'll talk about, but certainly something we should do as education and prevention of furthering a new population of people who might actually abuse these substances. So when OxyContin sort of fell off the radar, what happened was there was a rise in oxycodone. In fact, if I can go back a bit to the Bush era, he actually said, we won the war on heroin, and he showed a graph of heroin use plummeting. He did not show the graph of OxyContin use skyrocketing. And then when OxyContin was reformulated, we saw a rise in oxycodone, which is actually the active ingredient. And then when attention was brought to the abuse of that drug and how many deaths were being caused by that drug, pain clinics started prescribing methadone for pain. Well, then we saw an increase in methadone and a decrease in oxycodone. But when attention was brought to methadone as being a problem, and let me just say this, the methadone was from the pain clinics, not from methadone clinics. I actually called the head medical examiner for the state of Florida and asked him specifically, and they have a way of tracking the source of the methadone. And he was quite clear in saying that, no, these are prescribed methadone pills that are killing people today and that have risen in the abuse. In addition, he said, which is something we'll talk about a little later also, that 95% of the deaths related to the opiate abuse also had benzodiazepines in them. And 98% of the benzodiazepines were Xanax. But of course, we don't hear very much about that, which is very unfortunate. When attention was brought to methadone, what happened was oxycodone reemerged. You could see that, you know, regulating the opiates really doesn't impact what happens to the addict and their suffering of this disease. They're going to find their drug. So much money has been poured into the criminal justice system, not wrongly so, but so little money has been poured into the treatment field, which is really a shame because we've just been chasing our tail on this and have really actually now, rather than really having not seen much progress at all, we've actually seen a horrible worsening of the actual problem. In 1999, there were 4,030 opioid-related deaths. In 2010, there were 16,665. But the U.S. population only increased less than 10%. And during this time, believe it or not, despite all the evidence of the abuse of opioids and the prescription opioid crisis epidemic we were experiencing that time, despite all that going on, an acetaminophen, as Tylenol, acetaminophen hydrocodone formulation was being developed. Why was it being developed? Because some people were dying from liver failure from the acetaminophen. I wish I could see the look on your all's faces. Well, it was okay to have the opiate, which is killing people, but it wasn't okay to have the acetaminophen attached to it. So we got to do something about that. So in fact, what happened was the FDA approved a drug called Zohydro, made by Therapeutics, and also Purdue Pharma came back, the makers of OxyContin, and with its own version, Hysingla. And yes, it's hard to believe that we would do that during the time of such a crisis. Due to prescription drug abuse, states have been clamping down on pain clinics. Many states developed their own rules for pain and also developed prescription drug monitoring programs. Unfortunately, Florida was very late in that endeavor. Neighboring states were clamping down. While neighboring states were clamping down, busloads of people were coming to Florida for our pain clinics, getting excessive quantities of opioids and benzodiazepines. And this busing of folks from our neighboring states was eventually called the OxyContin Express. The Florida Center for Disease Control labeled Florida, the Federal Centers for Disease Control labeled Florida the epicenter of prescription drug diversion because it had weak regulatory oversight of pain management practices, limited regulation of physician dispensing habits, and most importantly, no prescription drug monitoring program. We became known as the pill mill capital of the country. According to the Drug Enforcement Administration, Florida had over 900 unregulated pain management clinics in 2010. These clinics employed 90 of the top 100 oxycodone dispensing physicians in the country. Of the top 50 oxycodone dispensing clinics in the U.S., 49 were located in Florida and were selling more than 1 million oxycodone pills a month. And let me give you a little sideline to that. At this time, legislation had been enacted by our government that stopped the DEA from prosecuting pharmaceutical distributors. They wanted to, and they were not allowed to. I guess you could say this epidemic we've been experiencing and are presently experiencing is quite multifactorial in its origin. Before new regulations were enacted by Florida legislature, it was projected from the state medical examiner's report that about 7 persons died each day of prescription drug overdose, primarily due to oxycodone abuse. It took, I was part of this process, I was consultant to the Board of Medicine when I was running the Impaired Professionals Program, 10 years for us to adopt a prescription drug monitoring program. When Purdue Pharma eventually got sued for their shenanigans with OxyContin, they had actually put money aside, they were forced to put money aside to pay for a prescription drug monitoring program in Florida. The legislature kept resisting and resisting and resisting. When we first started the process, we had 5 deaths a day. It increased to 7 and maybe even more. And by the time they enacted the legislation to get the prescription drug monitoring program up and running, Purdue Pharma were no longer required to pay any money. And so that came out of our pocket. So we started eForce, the Electronic Florida Online Reporting of Controlled Substance Evaluation, in 2011. Unfortunately, as of June 2016, only 23.7% of all licensed healthcare practitioners were registered to use it. It is somewhat cumbersome. It's not user-friendly, and they are working on it. There's new legislation before our House and Senate that is going to try and streamline the use of eForce so we can begin to see it used in other doctors' offices. Before they prescribe medications, they can actually see the last 90 days of prescriptions from all the prescribers of their patients' prescriptions. So that's what was happening with our prescription drugs. Well, the black market folks didn't like this very much, apparently. oxycodone was taking their market away from them. Heroin had not seen a comeback since it was at its peak just before the Bush era, as I had just said before. So what they decided to do was, let's make heroin cheaper. And sure enough, that's what they did. Heroin became cheaper than any other opiate out on the street or in the market. So now what happened was we began seeing increasing numbers of individuals using heroin and not the all too familiar and popular prescription opioids. I don't know if you know about this drug, and if you don't know about this drug, I would suggest you Google it. The good news, it never made it. Crocodile. I call it From Russia with Love. It was poor man's heroin in Russia. And it's a combination of basically gasoline, ethanol, codeine, red phosphorus, that's from matches, iodine, hydrochloric acid, and paint. Yeah, people were shooting it. Best high ever, as I've heard from people. If you go online, it's quite graphic. Be prepared, because people were actually walking around with bare bones exposed. It was very caustic to tissue. They did not live very long. We actually thought, while we had heard it arrived in Florida, I had one patient actually who said she had used it, didn't see her again, and I was getting prepared for the worst. What I thought at that point was going to be the worst of the worst. Well, it was a minor miracle. It didn't happen. And it didn't happen, I believe, because fentanyl arrived. And we'll go into quite a bit of detail about fentanyl in just a minute. So basically, Crocodile, as of 2013, stopped spreading. And that's when we started seeing, around 2014, the beginnings of fentanyl in our heroin supply. I now call it chemical warfare, and you'll see why in just a minute. The manufacturing and distribution of fentanyl and its analogs is more than an epidemic. It's everywhere, and I am going to prove that as we move along. The United States is in the midst of an opioid epidemic, with fentanyl fueling the crisis. Drug overdose deaths in 2016 most likely exceeded 65,000, according to the provisional counts of drug overdose deaths published by the CDC in August 2017. The death count is the latest consequence of an escalating public health crisis. Opioid addiction is now becoming even more deadly due to an influx of illicitly manufactured fentanyl and fentanyl analogs. And I will get into that as we move along. All right. So we've moved from the prescription drug epidemic. Now we're moving into the fentanyl epidemic, which again, as I said initially, is an extension of the prescription drug epidemic, but which has changed the entire landscape of the treatment field. It is actually something I would never have imagined in my entire life. What we're dealing with today is something like we've never seen, never predicted, and certainly are having a very difficult time managing. And as I will be speaking very shortly, urine drug testing is an extremely important part of our intervention, assessment, and treatment process. More Americans use prescription painkillers than used cigarettes, smokeless tobacco, or cigars combined in 2015. In 1999, there were 4,030 opioid-related deaths, and in 2010, there were 16,665, but the U.S. population increased by less than 10%. During 2013 to 2014, the number of drug products that law enforcement obtained that tested positive for fentanyl increased by 426%. The synthetic opioid-involved overdose deaths increased by 79%. In March and October 2015, the DEA and the CDC respectively issued nationwide alerts identifying illicitly manufactured fentanyl as a threat to the public health and safety. IMFs, illicitly manufactured fentanyl, are being mixed in unknown concentrations with heroin. In the fourth quarter of 2016, The DEA laboratory system noted a decrease in fentanyl seized from approximately 65% to 50% due to a 300% increase in furanol fentanyl. Now let me explain a little bit. We'll get into this in more greater depth. Fentanyl is 50 to 100 times more potent than heroin. Furanol fentanyl. Now, fentanyl can be reversed by Narcan, which we'll also talk about. Furanol fentanyl, actually, it is very difficult to reverse furanol fentanyl. And furanol fentanyl and another analog called acrofentanyl are in the Ohio Valley as we speak and probably headed towards Florida. There have been 9 other illicitly manufactured fentanyls, and that should not be morphine infusion. That was a typo. There have been 9 other IMF drugs identified aside from fentanyl. And carfentanil is more than 10,000 times more potent than morphine. Let me explain carfentanil just a bit. Actually, there was a bust out in, I think, the Tampa-St. Pete area not too long ago where they actually found 2 guys with carfentanil and readying for distribution. So a few grains of fentanyl can kill you. Even less of carfentanil can kill you. And carfentanil is not reversible by Narcan. Carfentanil is the drug that you put in a rifle to shoot a dart into a raging elephant. It will drop the elephant. That's how powerful it is. We've had a law enforcement officer who died because he accidentally inhaled some carfentanil that had been on the clothing of the person he was arresting. Our local ME's office has actually asked if they can get a supply of Narcan because they too are concerned that either touching it or inhaling it on some of the bodies in the morgue could lead to their own death. There are fire and rescue departments around the country where the EMTs and paramedics are carrying their own Narcan supply for their own use in case they have contact with this medication, with this drug. In 2015, 52,000 people died from drug overdoses. The peak year for AIDS-related deaths was 51,000 in 1995. Yeah, this is really scary. There are now greater than 140 deaths a day from opioids. Every 3 weeks, there are more deaths than due to the terrorism that occurred on 9/11. If you look at this chart, you can see that the number of deaths for 12 months ending in January 2017 increased 55% in Florida. Fentanyl is now killing more Floridians than any other single drug. Palm Beach County leads the state in deaths caused by that powerful opioid. In the first 6 months of 2016, a mix of street drugs, including heroin and fentanyl, killed 225 people in Palm Beach County. The deadly cocktail of heroin mixed with fentanyl or carfentanil figured in 220 deaths in Miami-Dade County in 2015. 90% of fatal drug overdoses in Broward County involved heroin, fentanyl, or other opioids. Just to run through this really quickly, I'm not going to go over all of this. Our number of deaths in North Florida are increasing exponentially. Overdose victims in 2015 were about 2,114. I'm sorry, that's 2015. Yes, in 2016, 3,114. 911 calls have tripled, and our the cost of transporting will have gone in 2015 from almost $2 million to over $4 million. JFRD, Jacksonville Fire and Rescue Department, is transporting 1 OD every 2 hours. The budget for naloxone has quintupled and is now 1/10 the medical supply budget spent. This is how it's going. There is no relief in sight. It continues to get worse. The morgue is continually over capacity. Duval County, the second highest in the state for neonatal abstinence syndrome cases in 2016. We don't have time to get into that, but that is a significant problem. All right, this is very scary. And this is where urine drug testing, we're going to introduce it now a little bit and get more and more into it as we move along. We began testing for fentanyl, point-of-care testing, upon all those who are heroin positive at Gateway Detox. And that's the detox center for Duval County and actually neighboring counties also. 100% of all heroin positive urines from these individuals were positive also for fentanyl. And that is an extremely important thing to understand. And let me just tell you a little bit why. I'm going to get ahead of myself, but I'll come back on it. Fentanyl doesn't stay very long in the system. Within a matter of hours, just a few hours, probably 2 hours, you're in very, very, very severe withdrawal. Now, what happens is now we're entering a biphasic kind of withdrawal because they have the combination of fentanyl and heroin that they took, and obviously they're alive, and luckily so. So you see the initial intense withdrawal, and you think it's over within a matter of just several hours because fentanyl has now cleared the system. But heroin is still lingering. So actually what happens is you see the intensity rise, you see it fall off, then you see a secondary intensity, not quite as bad as the first because of heroin. So testing for fentanyl in a detox is extremely important. We'll get into even more reasons why. And the only company I know is Premier Biotech that actually does point-of-care testing for fentanyl. The point-of-care testing is a little dipstick, and you actually get it responds to both fentanyl as well as its active metabolite, so you can pick it up a little longer in time. In Duval County, moving back to the slide, almost 2 deaths per day. How common is opioid dependence? Scrap the slide. That's why the slide's up there. Scrap all of our data. Everything you heard from me data-wise is really wrong. And let me tell you why. It's far worse. Number one, when you look at hospital data, you don't really know what is an OD and what isn't an OD. You can do Narcan reversal as part of it, but when you have to look at diagnosis at the time, it might have been diagnosis, heart attack, respiratory arrest. We don't know. So that data is not reliable. It's worse than that data. You look at the data of deaths coming from the ME's office. Well, the ME only does autopsies on bodies that were involved in a crime or suspicion of crime. They don't look at other bodies. So that data is totally underreported. And now I can tell you, many EDs, emergency departments, don't urine drug test. So we don't know what they were using. Many doctors' offices don't urine drug test. And many treatment facilities are not testing for fentanyl or its analogs. So we really don't know how bad the problem is. It's just far worse than we really know. Let's talk a little bit about the pharmacology of opiates. We're also going to get into the pharmacology of other drugs. Whoops, I keep pushing the wrong button. Sorry about that. The first thing to understand is what exactly happens in the body, the neurophysiology. Any drug we take has to find a receptor. Basically what happens is you've got receptors for all the different drugs out there, and when you take the drug it finds the receptor. It's sort of like a lock and key. The drug hooks up to the receptor, and then the action takes place. That's when you feel the drug. Now, we have opioid receptors. And I'm not going to go into great depth with this, but I think it's important for us to understand this as we understand, as we're going to understand urine drug testing and the interactions between drugs. The most common type of opiate receptor is the mu receptor. That's the receptor that causes us to get high. That's the euphoria. There are two other receptors. Delta we don't know a lot about. Kappa, and that's the receptor that causes our nausea, our not feeling so great. So most of the activity we are talking about is actually mu. These are the mu receptor drugs. You are probably familiar with all of them. Morphine, methadone, hydromorphone, codeine, fentanyl, heroin, buprenorphine, oxycodone, and hydrocodone. Interestingly, buprenorphine is the only one of those that has any significant kappa receptor activity. The function of a full mu agonist. So what that means is a drug that's a mu receptor agonist, or a drug that hooks to the mu receptor. When it's a full mu receptor agonist, it fully activates the mu receptor. Maximal potential. It hooks up, you feel everything you're supposed to feel. Highly reinforcing. The most abused substances includes, of course, heroin, methadone, oxycodone, and most of the others on the list. There is such a thing called the partial mu agonist. Now, partial mu agonist also hooks up to the receptor, the mu receptor, but only has a partial response. It's less reinforcing and it's less abused. The only drug we know of that we're using that's a partial agonist is buprenorphine. Interestingly, buprenorphine tends to hold tightly to the receptor. It really isn't a holding. It's like an electromagnetic force. It's a hovering. It's hard. It will kick most all the other opiates off the receptor and then have it take their place and have its action. Then we have a mu antagonist. These drugs hook up to the same mu receptor but have no effect at all, and they will kick everything off. So what happens is, let's say you're taking fentanyl, you could be taking oxycodone, you could be taking methadone, you could be taking buprenorphine. If you give an antagonist, which includes naloxone, which would be Narcan, as we're going to talk later, or naltrexone, an intravenous form called Vivitrol, and we call these opiate blockers. You give that, you kick the opiate off the receptor, the person goes into immediate withdrawal, and it's pretty severe. And we'll have to talk about that in a little bit also. Just FYI, naloxone, which is also comes in the form of Narcan, now you can do it intranasally. When you're in the ambulance and you're suffering with an overdose, they give it to you that way. When you're in the emergency department, they give it to you IV. Sometimes with the drugs we have now, they have to start an IV drip. And unfortunately, individuals will go into intense withdrawal, and if you give it, and you're giving the Narcan, it only lasts a few minutes, by the way, and the drug is still around. It just has been displaced off the receptor. The minute naloxone or Narcan goes away, which is a few minutes, the drug goes back on and they can go back into respiratory rest again, and they might require another dose, or, as I said, sometimes an IV drip of it. Here you can see a graph of what happens with an antagonist. Again, no activity, but it kicks off anything that's attached to the mu receptor, any of those opiates. The full agonist has full effect. Those are most of the drugs we know. And the only other drug, buprenorphine, which is the partial agonist, it has a partial effect. This is how it works. This is the receptors I'm talking about. Most everything we talk about when it comes to addiction is mediated by the dopamine system. It's actually a neurotransmitter. And anything related to euphoria, feeling good, reinforcement of that behavior. It could be hunger, thirst, sex, or drugs. Dopamine gets stimulated, gets released. And what happens is, obviously, dopamine is released, it hooks up with the dopamine receptor, and then you get the effect of dopamine. So let's see how that interacts with the actual opiates. We have our own internal opiate system. Endorphins, they are opiates. Our bodies are actually the best pharmaceutical company in the universe, well, at least on the planet. And endorphins are released in just the right amount for pain. And when endorphins are released, they hook up with the opiate receptor. Like I said, that's the mu receptor that we've been talking about. When the mu receptor is activated by endorphin hooking up with it, it then stimulates dopamine to be released, which then hooks up to the dopamine receptor, and then we feel the high. We feel the good stuff. It's exactly the same when you're taking an opiate. We'll use morphine for an example, but any opiate would be the same. Morphine, which is similar to the endorphins, would hook up with the opiate receptor, and once it hooks up with the opiate receptor, it causes a release of dopamine, which hooks up with the dopamine receptor, and then, and then you feel high. We have a very efficient system. I went back just a bit because I want to show you this. So when dopamine hooks up with the dopamine receptor and it's done its thing, it's then released, and it's taken back into the neuron that released it. It's actually the axon, the arm of that neuron, broken down and used again. So an extremely efficient system. It's a little weird doing this by webinar because I like to see heads nodding that people understand. I just have to hope and pray that you do. This is the area of the brain that is affected by the opiates we're talking about. This is where all that activity happens. It's called the mesothalamic area, or the limbic system, or pleasure center. Okay, something very important to realize, that fentanyl acts very, very quickly compared to other drugs. As you can see, its onset of action is 5 to 10 minutes, whereas morphine is 30 to 40 minutes. The duration of effect is fentanyl is only 1 to 2 hours. So if you remember what I was talking about, an individual coming into detox, for instance, having fentanyl and heroin, as I had said before, they're going through withdrawal from fentanyl, but the withdrawal from heroin is yet to come. Fentanyl leaves your system in 1 to 2 hours. That's when you're going to start going through withdrawal. Heroin leaves your system in 3 to 4 or 5 hours. That's when you're going to start feeling withdrawal. And that's the kind of thing you actually start seeing in your detox. The other thing that's extremely important to know, and we will get into more detail later on, is that most people think that when they're testing, at least point-of-care testing, those dipsticks and cups, that when they're testing for opiates, that they're getting a result of all the opiates they took. That's not true. The basic dipstick for opiates tests for the naturally occurring opiates. It does not test for the synthetic opiates. It doesn't test for hydrocodone, oxycodone. It doesn't test for fentanyl. It doesn't test for methadone. It doesn't test for oxycodone. So just because you have a negative test for opiates doesn't mean that they don't have opioids, I use the term correctly, opioids in their system. And no matter what you're doing in treatment, no matter what phase of treatment they're in, if they're coming into outpatient, residential, or detox, think it would be extremely important to know what it is they're taking. Obviously, we're not going to be able to believe what comes out of their mouths. So, for point of care testing, that screening of the cup or the dip, you really need to be understanding what you're getting and asking for the right kind of cups or dips. So you're going to want hydrocodone and oxycodone. But here, lo and behold, even if you ask for that, it's not necessarily going to pick up OxyContin. And it definitely isn't going to pick up methadone. Even though methadone's an opioid, it doesn't pick it up unless you specifically ask for it to be tested. It doesn't pick up buprenorphine unless you specifically ask for that test to be part of your point of care testing. And as I said, until recently, until we had the availability of fentanyl dip, we couldn't even get fentanyl on the point of care testing. So in order for you to know what you're treating and what to expect, you really need to be asking for the right kind of testing. And again, as I said, we'll be getting into that in greater detail. Now, I'm going to wind this part up before we take a break. So one concept I would like you to really understand and know is that the faster the onset of action and the more quickly it leaves your system, the more addictive it is. The longer it takes to peak and the longer it takes to leave, the less addictive. So when we talk about fentanyl, we're talking about a very rapid onset of action and a very rapid offset of action, whereas methadone isn't as long. It's very slow onset and very slow offset. Same with benzos. Xanax is much more rapid in and rapid out as compared to Valium or Klonopin maybe. And we'll get into all these details. I believe it is time for a 5-minute break. Thank you.
Dr. Pomm, thank you very much for that. Yes, it is time for a break, and we will start again in 5 minutes. Thank you. Dr. Pomm will give everyone about 1 more minute.
All right.
Good morning again, everyone, and welcome back to the webinar. We're going to go ahead and get started. Dr. Pomm, if you're ready.
Yes, I am. Welcome back. Okay, we have a lot of material to cover, so I'm going to pick up the pace just a bit. We're now going to talk a little bit about benzodiazepines. It's important information for even this discussion. I think you're all familiar with benzodiazepines. i.e. Xanax, Valium, and oops, I got to click in this slide again. Sorry about that. They're used as, for anxiety, as a sleeping pill, anticonvulsant, muscle relaxant, and alcohol as well as benzo withdrawal. Except for inpatient detox, really it's contraindicated in the addicted population. I've been in the field for a long time, and I can just tell you that I could probably count on 2 fingers how many people I've had to prescribe benzos to for anxiety or panic. We have lots of other medications, SSRIs, other antidepressants that are very effective in the treatment of anxiety and panic. And when you start prescribing, even with your drug testing, you don't really know how much they're using because it doesn't tell you how much they're using. Even if you get a quantification of the result, you don't know when they took the drug in relation to giving the urine specimen, so the quantification isn't really telling you how much they're using. I've seen the abuse of it way, way, way too much. Now let's look a little bit of the neurophysiology of benzodiazepines, barbiturates, which we don't see very much except in Furanol, Fiorset for headache. That's butalbital. Just to say, butalbital withdrawal is significantly more dangerous, more lethal than even is benzo withdrawal. If you don't know this, people that go through opiate withdrawal wish they were dying, think they're dying and wish they were dead. Benzodiazepines and barbiturates, they do die, and quite often from a seizure. This is what a GABA receptor. So we talk about mu receptors for opiates. So for benzos, we're talking about GABA receptors. That's the receptor the benzo hooks up to where you feel the effect. Very interesting. I put this up here because you have one receptor, but at that one receptor, different benzodiazepines hook up to different areas, or sedative hypnotics, I should say. You can see that barbiturates hook up to the same receptor. You can see that benzodiazepines hook up to the same receptor. And those drugs that are called non-benzo benzos, Lunesta and Ambien, et cetera, they also hook up to the GABA receptor. And I'm sorry, that's, again, a situation where you are being told erroneous information when it comes to the potential problems when it comes to the non-benzo benzos. I'll give you the list in just a minute. They are just as dangerous and just as addictive and have their own problems when it comes to withdrawal and addiction. I can say this: point-of-care testing, those dips and cups, okay, primarily test for diazepam, Valium, and its derivatives. So it might be Librium, might be people aren't abusing Librium. It might be Serax, they're not abusing that. And Valium. It is very difficult for those tests to show up Ativan, very difficult to show up Klonopin, even when they say it does test for it. And it's also difficult for Xanax. So a negative result on a point-of-care test, dip or cup, for benzos doesn't mean that they're not using benzos. That's what we call a false negative. So why is that important? And I want to show you this real quick. So I'm going to give you an example. You can see the half-life. It takes about 5 half-lives for a drug to leave the system. The half-life of Xanax. Half-life is how long it takes for half the drug to leave your system. And again, 5 half-lives pretty much clears the system. Xanax, half-life about 12 hours. You can see clonazepam or Klonopin, about 50 hours. Diazepam, it says 20 to 60 hours. This is not totally complete, because if you add all the active metabolites to diazepam, you're running somewhere between 100 and 200 hours before it clears the system. Why am I telling you this? So I had an issue that came up. One of the providers I work with had started a Klonopin taper for Xanax. She admitted she was using Xanax, and she was positive for Xanax. So we started a Klonopin taper, which is not unusual. And 6-7 days into the taper, it's about an 8-day taper, the patient started complaining of withdrawal symptoms. So the provider comes over to me and says, "Doc, look, this woman's drug seeking. We need to do something about her. You know, let's move her out. Let's get her into residential, whatever we need to do, the next level of care. But she is drug seeking big." I said, "Hold up. Tell me what her drug test was positive for." "Xanax and Valium." Well, Xanax, you start going through withdrawal within about 24 hours. Guess what? Because Valium has such a long half-life, you don't start going through withdrawal until somewhere between day 6 and day 8, and she was day 7. So the Klonopin is already leaving her system. That had done its job with Xanax, and now she's going through Valium withdrawal. If we had sent her up to residential treatment or discharged her, a couple days after that, she would have been at very high risk for seizures. Risk for seizures for Xanax, somewhere between 24 and 48 hours. Risk for seizures for Valium, somewhere around day 7 to day 8. So it's extremely important to understand that. Very similarly, going backward, buprenorphine, its half-life is 36 hours. I had someone come in, they wanted to be detoxed from buprenorphine. I said, well, you know, you come back in 4 or 5 days. They don't start going through withdrawal from buprenorphine until somewhere between day 3 and day 5. So again, the same kind of thing can happen. They could be positive for another opiate. You're treating that withdrawal, and then all of a sudden it starts getting worse because now they're going through withdrawal from buprenorphine. If you didn't test for buprenorphine, you wouldn't know that, and you would be making all sorts of wrong assessments and wrong recommendations. I hope I'm making my point here. And these are non-benzos, again, their own inherent problems. And the point-of-care testing and the cups or dips don't test for non-benzos. I don't know of any that test for the non-benzos. I actually had a patient came in negative on everything. She denied using Xanax, denied using anything else, and within 48 hours later, she had a seizure. Well, we come to find out she never told us about the Ambien she was using. That's a mouse or rat. I think it's a mouse. Anyway, he's got a needle in his limbic system, and we are giving him, let's say, every time he presses, we're going to give him cocaine. That mouse is going to go, you know, slap that thing really hard, not eat, not sleep, and then he dies. Okay. That's with cocaine. With opiates, he's going to do it a little bit, take a rest, take a little nap, eat, drink, go back, do it a little bit. Same with benzos. Just to give you an idea of the effect on the mammalian brain. I don't have any evidence. I don't have what would happen with fentanyl, but my guess is the fentanyl is going to be somewhere between the cocaine behavior and the opiate behavior. When you combine benzos and opiates, you stop breathing. and then you die. So it's extremely important to test for both, to know what is going on and what to expect, and understand that, you know, they're dealing with one drug. Well, if you don't know about the other drugs, that can be a real problem moving forward and determining what is the best course of action for individuals, both in detox as well as in longer-term treatment, whether it be outpatient or residential. Alcohol. Yes, it is a drug. I guess we all know that. Good, bad, or just ugly. It's illegal. We are not talking about legalization of marijuana, by the way, today. 15.1 million adults in the U.S. suffer from alcohol abuse or dependence. 2015 number. You all know about BAC, blood alcohol concentration. This basically tells you what level and then basically and then how impaired they are. But don't let us fool you with tolerance, which we'll talk about in just a minute. They can have a point. I've actually seen a 0.48 walking and talking. One more drink, he probably would have died. I've seen many occasions 0.3 to 0.4, walking and talking. It's amazing what tolerance does. A little bit more drinking, and he's dead. I will say this, alcohol testing is not extremely valuable, not when it comes to urine without specialty testing, which we'll mention later. Alcohol testing by urine tells you basically that they have drank sometime in the last 12 to 24 hours. That's it. Doesn't tell you how much. And the reality is, it might clear the system even quicker. So a negative alcohol on urine does not mean they're not alcoholic. Doesn't mean they haven't been drinking. It just means you're getting that test further out on the timeline, further distance on the timeline compared to when they actually had their last drink. Alcohol actually, through the metabolism, it decreases by 0.015 milligrams per hour. So you can actually do the math a little bit about how long they've been drinking and how much they've been drinking. Average male reaches 0.08 after 3 to 4 standard drinks. Typical night out sees a BAC of 0.1 to 0.2. And BAC is by breath. It does approximate very accurately how much is in the blood, even though we're getting it in the breath. Impairment lasts 20 to 30 hours. And why does it last that long? Because when they're hungover, they're in a state of dehydration, hypoglycemia, not able to walk quite right, sleep debt, cognitive impairment. They usually don't show up to work on Monday. Talk briefly about tolerance. I'm not going to go over all these slides. Basically, but I do suggest you read them. The more you take of a drug and the longer you take it, the more it takes of that drug to achieve the same effect. That's the bottom line on tolerance. All drugs you get tolerant to. Methadone, less so than many others. Buprenorphine, less so than many others. Most of the others, tolerance is very rapid. If you look at Xanax, they actually did a study. And Ativan, you start getting tolerant to those drugs within 5 days of initial dose. With Xanax, you get tolerant to the interdose intervals. So when you're taking every 4 to 6 hours, you start feeling withdrawal between doses because of interdose withdrawal and interdose tolerance. Withdrawal symptoms from Xanax are almost identical, if not worse, than the original anxiety symptoms you were treating with Xanax. That's a horrible negative vicious cycle. And I can tell I don't like that drug. I actually don't start it on anyone. I take everyone off. Okay, this is important. Once tolerance to a drug effect is developed, it is not irreversible. A period of absence from a drug increases user sensitivity to the drug effects they may have been highly tolerant to in the past. Acute tolerance reverses in a short time. However, protracted tolerance requires more extended abstinence to reverse. So I do suggest you look at that slide a little quicker, a little more in depth. All right, then what happens when you mix heroin and fentanyl? So let me say this. We know that fentanyl is 50 to 100 times more potent than heroin. We know that. Someone shoots up heroin, and as I've already said, 100% of the heroin we've experienced has fentanyl in it. We don't have a clue how much. So let's say someone's been shooting up heroin in their life with no fentanyl in it. Now all of a sudden we put fentanyl in it. Well, now all of a sudden we're giving them a drug they're not tolerant to because they've achieved a level of dosage of heroin based upon tolerance. You know, again, the longer you use it, the more it takes in order to get the same effect. So they've achieved a certain level of heroin use in order to get that effect. Now you add fentanyl in it, which is 50 to 100 times more potent, and then you don't know how much, and then you stop breathing. We used to, in the addiction field, say that with addiction, we're playing Russian roulette. Well, as I said initially, the entire landscape of what we're dealing with and the treatment of it has changed. Now they're dealing with a gun. They're playing Russian roulette with a gun that has 4 or 5 or maybe even all 6 chambers loaded. We also have said that addiction hijacks the brain. And I can say this with a lot of assurity. Fentanyl hijacks the mind, the body, and the soul. I had a patient, I'll quickly say this, who had 20 friends die. She had been in recovery, relapsed on heroin, knew there was fentanyl in it. Again, I said 20 friends had already died from that combination. She had a 13-year-old son, and she called her old sponsor. She had 1 bag left, and she said to her sponsor, please, I'm getting ready to shoot up my last bag. Do me a favor. Make sure you get my body out of there before my son sees it. Folks, it had her at every level. You're under the influence, you're totally impaired. Within an hour or two, you're going through such severe craving and withdrawal, you have no choice but wanting to go back out and use. Our EDs, emergency departments, put you in that severe withdrawal, and then they put you on the street. And that's something we have to deal with. We have to work with that. We have to figure out what we're going to do about all this. These are some of the analogs. I've already talked about fentanyl, carfentanil, 100 times more potent than fentanyl. Okay? That means it's 10,000 more times potent than morphine. That's out there. It's already here. It's in Florida. It's around this country. It's immediate death. There's no coming back. There's no reversing. And I'm not being overly dramatic. You're not seeing sufentanil yet. We're beginning to see acetylfentanyl, furofentanyl, I already said acetyl. Furofentanyl, those are the ones that are in Ohio Valley, and they are very hard to reverse by Narcan. And let me just say this very quickly. Our paramedics and EMTs are going through compassion fatigue. It's very difficult for them. They're watching people come back and back and back. They're watching people dye their hands, all because of these ODs. It's very difficult at every level of society at this point. Well, Ching Labs, why did I put that thing up there? Because they're the ones that have been producing all this fentanyl. Yes, China and Ching Labs. I don't mean to be too facetious, but I know President Trump will be talking with the President of China, according to what he said yesterday. I'm not sure what that's going to do because the President of China already knows this. They've already said, well, we don't like this, we're going to regulate it, and Ching Labs makes different illicitly manufactured fentanyls, the IMFs, analogs, greater and greater potency, and they're still sending it out. It is coming through the mail. It just takes a few grains. You can embed million doses in a very small, in a package, and it's just totally embedded, or in cargo ships or container ships or trucks. No, they're not coming over the border through the wall, any walls that are or aren't there. It's coming through other areas, planes, trucks, through the natural borders. This is where it's coming, and it's been coming. It wasn't too long ago, and can still do it, but you can order it online from this lab. And I haven't checked recently, but it was like $600 for a kilo. A kilo would kill millions of people. So I said earlier, we're dealing with chemical warfare, and I say now we are dealing with chemical warfare. This is a chemical coming from another country, and it is killing our people in greater numbers than any chemical warfare in the history of this country. So let's talk a little bit more about urine drug testing. ASAM actually put out a consensus statement regarding urine drug testing. This consensus statement came out after there was a lot of abuse of drug testing, so it certainly came out as guidelines. A lot of this you probably already know. I'm not going to go over absolutely every part of this, but I will highlight some areas. I do want to make a point that drug testing is a therapeutic tool, okay? It's used in assessment. One of the things I want to happen is, primary care docs are the front line here. They're not drug testing. What happens if you have urinary frequency and burning and frequency? The doctor gets a urine test to see what's in it so he can treat for a urinary tract infection. Well, what happens when you go in and you have some suspicious behavior, or they're not quite sure what's going on because they don't know what to assess, but they won't get urine drug testing? Well, how do you get a complete history on someone if you don't know the drugs they're using? And as I said, the vast majority aren't even checking the prescription drug monitoring program, eForce, to see what prescriptions they've had, let alone the street drugs they've had. So anyway, you got me going. Well, I got myself going. Sorry, you're not there to push me on. And of course, it's used to look at identifying substances of interest. One of the things that drug testing, I really need to make this point clearly, is being used for when it comes to a therapeutic tool. We often get carried away. I've seen it happen a lot. You used, and then people approach it in a confrontational way, the use. Sorry, that's not the use. We're trying to motivate people to want treatment. We're trying to motivate people to try and get into recovery, not just kick them out. We're discharging people this day and age, especially with fentanyl on the street as it is. We really have to think hard and fast, because if we're just discharging for positive urines, we are sending them to their certain death. It's no longer, as I said, just Russian roulette. We're sending them out there, and they are most likely going to die. We need to educate people. We need to help motivate them, as I said. And if they refuse a drug test, we need to explore that with them. Yes, it's going to be a positive, but we certainly need to explore that with them. Now, I've already made a point of saying that in order for us to know exactly what to do, we need to see what the results of the test are. We need to know what tests we're using. Because if we don't know what drugs we're testing for, then how can we use it to assess what needs they have? On top of that, it can be very helpful in determining optimal placement and level of care. If someone's telling you that they're using X, Y, and Z drugs, but all of a sudden you see all sorts of other drugs on there, well, their level of denial is quite severe. On top, and beyond that, the type of drug they're using will lead to more questions about withdrawal symptoms, where they're living and access to those drugs. How dangerous is it for them to be out there? There are all sorts of things that come in when you start seeing what they're not telling you. Now, individuals that come in with an altered mental state, okay, as I have made mention before, a negative test does not mean they're not using. It's the type of testing and what you're actually looking for and expect to see and what you're asking for is extremely important before you make that determination. Make sure, please, whatever you do, make sure you document every reason why you're getting the test and the results of the test. You're going to be approached by various labs. Make sure you're speaking with the lab about what kind of substances you want to look for. Make sure you understand clearly what you're not getting and what you are getting. Again, this is extremely important as part of your assessment tools. The selections that you pick should be individualized. If there's a lot of amphetamines in your area, well, you might want to pick amphetamines. If you haven't seen any amphetamines but you've been testing for it, well, maybe you don't. I don't know. For me, definitely I want to see benzos and opioids because that combination is lethal. I know it's lethal. I want alcohol testing for some people. That could be very lethal. At a minimum, I'm testing for the lethal combinations out there. But I don't have time to get into all the specifics of that. Now, excuse me. When you get an immunoassay panel, that's a point of care testing, or the strips or the cups, okay? Make sure you look at the insert. Make sure you talk with the rep about what exactly is being tested, and we're going to get into some detail of that in just a minute. Cutoff levels. How likely is it to actually show it? Know the limitations of that testing. The old 9 to 5, throw it out the window, please, okay? You can get much more extensive than that. Also, make sure, and as I've said, that this day and age you need to be testing for fentanyl. And also its analogs, and we'll talk about that in just a little bit, which are coming your way, and we need to be prepared for that. As I said a little bit before, there's no room for confrontation here. Okay. Immediate abstinence might not be a realistic goal. You need to consider all factors, including, again, as I said, and I can't repeat it too often, the results of what happens if you discharge because of a positive test. But you also have to consider what happens if you keep them with a positive test. It gets very, very difficult. Now, I'm sorry, whoops, back. Now, what happens if you're not quite sure? Whatever lab you're working with, make sure they have good support, 24-hour support to answer those questions. Make sure you don't just guess at what you think it means. Make sure they're testing for adulterants. One thing I do want to say, dilute urines, that's a little tricky. Sometimes a lot of drinking of water can be dilute. It's not intentional dilution, because intentional dilution definitely is considered a positive. When I was running the Impaired Professionals program, a creatinine of 20 or below 20, was considered dilute. Well, I was sending people out to the nephrologist, the kidney specialist, on a regular basis and finding nothing. I eventually realized that actually somewhere between 15 and 20, for those people that exercise a lot or drink a lot of water, is not unusual. And so for me, in my own personal practice, 15 and higher for me is a little better. It becomes acceptable, assuming they tell me the right kind of history. Now, if I'm unclear and I'm unsure, what I do is very simple. So I have a suspicious urine, I have a dilute urine, I'll then have them wait and sit and have them drop again, back-to-back urines, because what they did to dilute the first urine is not going to hang around for the second urine. And I find that to be very, very, very beneficial. And make sure that if you're getting the right kind of testing, that they're also testing for any adulterants that might be in there. Okay. As far as frequency goes, it should definitely be random, number one. Number two, initially it should probably be weekly. Eventually, as they stabilize, to monthly. Of course, any suspicion should be tested for. Okay, let's talk about some of the technology. We've been talking about the dips and the cups, and that's what you're seeing here. That's point of care. And point of care testing uses immunoassay. You need to understand point of care is not, that's what you're doing at your place of practice, your agency. It's not usually a laboratory-derived issue, though there are some labs that use the same technology and charge you a lot more for it, but you might be getting a little benefit. I won't get into all that. Point-of-care testing, or immunoassay testing, it's qualitative. Okay? It tells you whether a drug class is present, i.e. opiates. Remember I said if you don't specifically ask for if you don't ask for a specific opiate to be tested, opioid to be tested, you're not going to see it there. And even then, it might not be very accurate because cutoff levels on immunoassay are quite high. Well, if you don't achieve the amount of drug in your system at that cutoff level at that time, you're going to test negative. That's a false negative. Also, which I'll show you in just a minute, there can be an interaction with other drugs that look like or look similar to the drug you're testing for, and it hooks up because of the type of technology, and that'll show positive. Zoloft for benzodiazepines is an example. That's a false positive. So with point-of-care testing, the reality is I use that as an initial point of discussion and therapeutic intervention. I can't make a final decision about that. I can tell you, however, in Duval County, I'm very frustrated with this, they're making decisions regarding custody and placement of children based upon this type of testing, which, as you can see, is not very accurate. You're talking upward of 50% false negatives and false positives. That's how unreliable and invalid it is, though it can be of some benefit, like cocaine. Cocaine's usually cocaine, okay, as an example. And if it is positive for the drug you're testing for, you know, unless there are other drugs on board, it usually is positive. And quite often, if they know that you're going to do further testing, they'll fess up right then and let you know. This is just how benzodiazepines metabolize. As I said, a benzodiazepine point-of-care testing is usually diazepam related, as you can follow that down, and it's very difficult to get Klonopin, possible but difficult, Ativan, and Xanax. I've already talked about that. So urine is the most well-established and well-supported biological matrix. Blood, you don't even consider blood. That's just not an option. It's just what's in the system right then at the time. It doesn't give you use over the period of time. Oops, sorry about that. I'd already mentioned some medications like Tylenol with codeine, Vicodin, Dilaudid, morphine, Percocet, oxycodone, heroin can result in a positive screen. All right, positive screens can result when interpreted in many ways. So basically, you know, there's certain things that can just show up positive because of the type of technology that we're using. Let me go back a bit. I'm sorry about that. It's not something you can totally rely on. Now, I want to show you this, the metabolic pathway for opioids. I do, again, need to repeat that the opioids you're getting, generally speaking, on immunoassay are positive for the morphine derivatives, okay, the morphine or codeine derivatives, not for the others. You have to ask specifically for the hydrocodone, oxycodone, and also for the OxyContin, as I had already said, as well as methadone separate, buprenorphine separate, and fentanyl is now separate. Poppy seeds. Yes, poppy seeds can test positive for opioids on your point-of-care testing, okay? One difference is this. It usually, and you don't know this unless you get further specialized testing, confirmation testing, where you can see with poppy seeds, you usually get a positive morphine, but not necessarily a positive codeine, whereas with all the other naturally occurring opioids, you get both codeine and morphine. Either way, it can be confusing. This is how I usually handle this. I do educate them up front, stay away from them. If they use it as an excuse and I'm not sure, I certainly call the lab. And if neither of us are sure, then what I say is, you got the one pass. From this point on, no more poppy seeds. Any positive urine for opioids will be considered a positive, and we will have to deal with that accordingly. As you have seen, there are new fentanyls out there, new synthetics out there. We've mentioned acetyl fentanyl, butyl fentanyl, carfentanil becoming a major problem. Okay. And those are not picked up by point-of-care testing. There's something we really need to know about as they're approaching our areas where we live. Really, what we're going to talk about next, LC-MS-MS, and I'll talk about that in just a minute, is the best way of testing, confirmation testing. It's liquid chromatography, mass spectrometry, mass spectrometry twice over, tandem. Actually, Premier Biotech, and again, I have to say it because they're on the cutting edge, they actually are now testing. They're the only lab I know that actually offers testing for the newer synthetics that are showing up in our country and in our area. And they actually have a panel of tests for, these are the expanded, this is the expanded fentanyl offering that they have, which I think now is very valuable. We're starting a pilot project here. They've been gracious to do free testing just for the pilot and research aspect of the project. And we're going to be testing for this because we're really interested in seeing what is the trend in our area. And I do not like to be blindsided when it comes to people showing up and not knowing exactly what they've been using if the technology is out there for us to know. So a little bit deeper in this when it comes to point-of-care testing. Immunoassay uses antibodies, and the antibodies recognize a segment of the drug, but that segment of the drug might look like that might be shared with another drug, and that's where the false positives come. So when it hooks up, that's when it shows positive. So when it hooks up with Zoloft, there might be a part of Zoloft that looks like a benzodiazepine, so it shows positive for benzodiazepine. That's how that works. There are lists and lists of drugs that this can happen with, and it's extremely important to understand that. A little off that type of thought thinking, there's another way it can be false positive, and that is like with a Vicks inhaler. A Vicks inhaler has a molecule, an amphetamine molecule. That's a mirror image of the active amphetamine molecule. It'll show positive for amphetamine with Vicks inhaler, but it isn't the active amphetamine, and that takes further testing to understand that. So there are a lot of, again, as a therapeutic tool, as an initial assessment, it's extremely important to get that point-of-care testing. You get an immediate result. It's a discussion point. It might be a direction to start treatment, start the assessment process, but to really know what they're using, that's where the actual confirmation testing comes in. In confirmation testing, how that works is it looks at the entire molecule. It verifies it by weight of the drug, okay? And that's mass spectrometry. And now what happens is it identifies the actual drug, so there are no false positives. The only false negatives you can have really are with the cutoff levels, but the cutoff levels are so low, I don't see false negatives either. And when you get too low on the cutoff levels, and I've experienced this already, you start getting some interference, so it becomes a little problem. But the type of testing most labs that are offering with liquid chromatography, LC-MS tandem, offer reasonable cutoff levels. And basically, you're not going to find false positives and false negatives. What you get is what you get. It's so important, it's very interesting, that when we start doing confirmation testing on all of our clients, They will tell us when we drop them through point-of-care testing and immunoassay testing, when we drop them for that, they'll automatically say, I might as well tell you I used. When we were just doing point-of-care testing, no, it was a guess. They knew it was a guessing game. They would already Googled all the possible reasons they're having a false positive or a false negative, or a false positive, I'm sorry. And it'd be a very difficult situation because they might be right. But with LC-MS-MS, it is what it is, and they understand it, and it's been one of the most therapeutic tools I've ever used. I do want to talk a little bit about this. I had mentioned that alcohol testing is not very reliable when it comes to just the basic urine alcohol, because what that tests for is how much alcohol is in your system since your last drink. Alcohol goes very quickly, 0.015 milligrams per hour, an ounce an hour. That's how quickly it goes. And your urine is not going, the typical urine test is not going to pick it up any longer than that. Even if it might not even take it all the way out to its endpoint. So a positive alcohol is usually indicative of very recent use. But that can get confusing too, because diabetics can have a positive alcohol because they ferment glucose in the bladder because of the yeast they have, and they can show positive, and that's a false positive for alcohol. I've actually seen some false positives after they've had a needle stick from a hospital where they've rubbing alcohol in that area. Not usual, but it's not a very reliable test. Of course, it being positive and the person admitting it, yes, it's definitely worthwhile looking at, getting, and having that discussion, as I said before. There is a way to test for alcohol use up to 3 to 5 days after use. That's called ETG, or ethyl glucuronide testing. About 1% of alcohol goes through this minor metabolic pathway. Okay? It can be very reliable. It came out quite a while ago. I used it in the Impaired Practitioners Program quite a bit. I would suggest if you use it, 500 nanograms and higher are the true positive results. Anything below, it's questionable. There's something like 200 different bacteria that can cause a false positive with ETG. But I think it's still important for those people you choose to use it on, and I'll talk to you about that in just a second, because we actually, and I just suggest you read through some of these slides if you choose to do this and work with the lab that's going to be doing the testing. They now have another test, ETS, ethyl sulfate, another minor metabolic pathway. It actually offers, in combination with ETG, it gets rid of those false positives from the bacteria. It also gets rid of some of the other confounding variables. So when we get both, we know pretty much that that person has been drinking alcohol. You all have a question to ask yourselves, though. How much do you want to know that? Because it will pick up even a couple of drinks. I don't know what your all's philosophy is. I can tell you we are abstinence-based. But at the same time, we are capacity limited, both therapeutically as well as beds and just basic space. My recommendation is, for those people you are suspicious of using alcohol or drinking, that certainly you should do this. Whether you do this on a regular basis or not, you really need to look at the pros and cons of ETG, ETS. Because you know darn well, alcohol in combination with the other drugs can cause death. Drinking alcohol is not recovery. We know that. But you have to weigh that all out with what you're able to do, and certainly it is a powerful, powerful discussion tool. I hope I'm making some sense. Again, I can't see heads nodding or glazed over looks, so I'm going to keep moving on. You're going to find some labs offering GCMS, not many anymore, but that is an older technology, and I'll just shorten all this to say that with gas chromatography, mass spectrometry, which is the older technology, they had to make, I'm going to make it real simple even for myself, they had to turn it into a gaseous form. You're going to lose and distort some of that molecular structure by turning it into a gas. Liquid chromatography, LC-MS, is a cold process. You don't have that. So LC-MS is much more reliable, and you really don't get the false positives at all. So that's pretty much the technology any lab you go with. I would be asking those questions about what technology you're using, and if you can have a lab, find a lab that is using LC-MS, I would certainly steer you in that direction. If you want a result, you can totally rely on it. Oral fluid testing. It's coming a long way. We don't have point of care yet. I can tell you again, and I hate to keep bringing this up, but Premier Biotech is ahead of the game on this also. They have in the FDA line for approval a point of care saliva test. That's one of the reasons we don't use saliva very much, is because we don't get that immediate result. I'm hoping they get that approval soon because it'll be a great benefit. You can read through all this, but basically it's not gender specific. It's really hard to contaminate or somehow cause problems. Shy bladder issues go away. You can watch, you can obviously, since it's not gender specific, you can have direct observation during the collection. The risk of adulteration, substitution, dilution, additives is pretty much eliminated, and it's very fast collection time. It works really well, and whatever lab you choose, I strongly suggest you talk about what they're able to test for through urine, through saliva, and saliva is typically tested through confirmation testing, which is LC-MS tandem or GC-MS. It's a great for in the field case managers. You know, when you go into a house, you don't always have the right gender there, or people have every reason in the world why they can't draw. Well, saliva. It's an answer. It really is an answer. Hair testing. You've probably heard of it. I use it once in a while. Don't use it much. You can actually see drugs up to 3 months. Most valid 1 to 2 months. A lot of labs don't do it. There are only a few labs that do perform this. However, you got to understand the collection is invasive. They have to cut about an inch worth of hair. It's a clump, and you know, some people might not like that even if they have long enough hair to cover it. The results do not hold up in court, so don't expect to take it any further than your own therapeutic reasons to have it. Again, whatever reason you get, whatever test and why you're testing, document, document, document. It's going to be extremely important for you in the lab. You know, person at high risk for relapse, why you're picking the specific drugs that you're testing for, because all this gets charged out, whether it be the Medicaid, private insurance, it all gets charged out, and one day you will be audited as well as the lab. And if you don't have documentation as to the frequency and the types of drugs you're using and why, then you're very vulnerable to lawsuit. So absolutely do it, but absolutely document. Let's look at a couple of case vignettes before we close up. So a 25-year-old female in detox appeared with an altered mental status. She was sent to the emergency department. She came in with a positive test for benzodiazepines and a positive test for fentanyl. She came back from the emergency department with a diagnosis of altered mental status examination. Oh boy, that didn't help. That's why we sent you there. They did not do urine drug testing, I can tell you that. So we send her back out to see if we can get another opinion. And they sent her back. Same diagnosis. And I said, okay, this is a little weird. We need to get drug testing now. Well, the staff said, but we already did just like a day and a half ago upon admission. I said, okay, we need to get drug testing now. They did. She was positive for fentanyl. Remember what we talked about. Fentanyl leaves the system really quick. She shouldn't still be positive for fentanyl. Now I know why she has an altered mental status, probably. It's because when we sent her to the ED, the emergency department, she hooked up with someone or somehow found fentanyl and used it there and comes back, and here she is now walking around naked and talking to herself. So I said, send her to a different emergency room because we're going to confound this whole thing. If she's hooking up with a certain person at the emergency room, we'll send her to a different emergency room. Don't say anything to anyone. Boom. They sent her back with a darn altered mental status exam, altered mental status result again. No urine drug testing. Tested her again. She was positive for fentanyl again. She shouldn't have been. It should have cleared the system by the time we sent her that time. Now she was positive for benzos too. Well, she had already cleared out the benzos because we know that from the second test that we did. She was positive upon admission. She was positive. She was negative on the second test. She's positive again. So she went out and used fentanyl and benzos. Well, I had to make a decision. It was not an easy one. There could be many reasons for altered mental status, and some I don't even want to think about. But at this point, I was getting nowhere with the system. I said, okay, we cannot send her out again right now. I'm going to have to just watch her for the next 24 to 48 hours. If she clears, we know it was totally the drugs. If she doesn't clear, we know she couldn't have gotten to the drugs, and we know that it's something else. And then I'd have to talk to the ED doc and try and push the issue. She cleared. When she was clear, she told us what she did. And the reality was she had the drugs in her bra, and when they searched her, she held them against her bra. When she walked around naked was when she no longer had access to the drugs because she didn't have a bra on. And they had her shower, and then, of course, they searched her clothes thoroughly. And it's tricky business, but you can see how valuable urine drug testing was on that case for sure. Medication-assisted treatment option. Whoops, what happened? Uh-oh. Oh. Somehow, I got to move fast through this. I'm sorry, folks. I'm not sure how that happened. Went all the way back to the beginning. Give me just a second, and I'll get caught up with myself. Getting close. Okay, I'm going to give this brief rendition on the medication-assisted treatment options because that is one thing that's going to get us somewhere with this new epidemic with fentanyl, the one that's actually killing us at this point in droves, as you've seen. We talked about methadone. Methadone works really well for the prescription opioid epidemic. It really does. Highly regulated, it's through methadone clinics only. DCF, DEA, Board of Pharmacy regulates all this. Gold standard for pregnant women. Actually, buprenorphine's right up there now with it. It's a whole other discussion. It certainly stops withdrawal, symptoms, and cravings. It's the most researched medication used in the treatment of addiction. They don't get high once stabilized. Tolerance is not as much of a factor as I had already discussed. Okay. And as I also said, don't confuse it with that which was abused coming from the pain clinics. Methadone, again, works very well for prescription opioid dependence. It's not working as well for fentanyl. Why? Think of it this way. They're on methadone, a stable dose. You got to that dose by assessing withdrawal symptoms, then you increase the dose so they no longer have withdrawal symptoms and cravings and everything's good, and it stays that way. Now they take fentanyl. Fentanyl is more potent. It kicks methadone off that new receptor. It now takes over. It makes them high, and within an hour or two, now they're going through withdrawal, bad withdrawal. They come into the clinic, you see withdrawal, you increase the methadone. You're increasing methadone because of fentanyl. That's a rabbit hole you don't want to go down because it will lead to your eventually killing the person. You need to be testing for fentanyl to know what you're dealing with. We're having to deal with that. It's very frustrating. I'm not kicking them off the fentanyl. I'm going to send them to their death. Don't want to do that. Got to intervene. Lots of different therapeutic tools out there to be used, and I will not increase their dose of methadone based upon a positive fentanyl urine. Those are some things I've already implemented. More to say about that, but don't have the time right now. Case vignette 2. And this is exactly what's been happening. 26-year-old female, stable on 120 milligrams of methadone, presents with withdrawal symptoms. This person had a positive fentanyl. And we had to do what we had to do. Unfortunately, somewhere between 40 and 50% of our folks on the methadone clinic are positive for fentanyl. It is becoming a significant problem, and we're having to manage it in a whole different way than we ever have before. Suboxone or Subutex, actually we're now talking mostly about buprenorphine. Buprenorphine, as we said, is a partial agonist. It works really well when someone's in withdrawal. You can start it. It's very powerful at the receptor. It basically keeps all the other opiates off the receptor. It doesn't keep fentanyl off the receptor when fentanyl gets to a certain dosage. Here's how it works, though, for fentanyl. Remember, you're either impaired because you're under the influence or you're going through severe withdrawal craving. Well, when you're in withdrawal and you give them buprenorphine, do the induction, you stop withdrawal. Now you stop withdrawal, you stop the craving, and they're no longer high when you get them on stable dose. That all happens within basically 24 to 48 hours, very quickly. So now the individual is no longer under the influence, no longer going through withdrawal, and not going through craving. You're 3 steps ahead of the game, and they're using fentanyl again. And they know clearly if they use fentanyl again in order to override the buprenorphine, they're actually trying to kill themselves. So you're way ahead of the game with buprenorphine. I do want to give you an interesting little vignette. 45-year-old male on buprenorphine tests positive for naloxone. Well, buprenorphine plus naloxone is Suboxone. Naloxone doesn't work by mouth, but it helps hinder the IV administration, but only partially. That's another story we don't have time for. However, this person's on buprenorphine should not be testing positive for naloxone. Should not be. Turns out his wife is being prescribed Suboxone, which has naloxone in it. He is using his wife's Suboxone and selling his buprenorphine on the street. And I would not have known that without testing. Vivitrol, it's an opioid antagonist, it's a blocker. It works as an injectable form of naltrexone. It works really, really well. It's not mood altering, not addictive. It's a monthly injection. You don't have to worry about compliance, which we did with the pill form of naltrexone. The downside to this only is that they have to be off opiates for a good number of days, 6 to 8 days, before you can start it. If they're in treatment, it becomes a great situation, even detox, if you can hold them that long before you start it. That's the downside. The upside is this, as I said, it's not addictive, not mood altering, and they don't have cravings, and they don't go through, they're no longer going through withdrawal, and it actually blocks the activity of fentanyl to the same extent that buprenorphine does, and that you're 3 steps ahead of the game, and they'd have to intentionally want to die and override with fentanyl. So at least you're 3 steps ahead of the game, and these are 2 drugs, buprenorphine and Vivitrol, that really gives us a head start on treatment for these individuals. Here, however, is a 54-year-old male using Vivitrol. By the way, Vivitrol works well for cravings for alcohol. It also reduces the euphoria for alcohol, but does not reduce the impairing effect of alcohol. So people who drink on it don't feel high, and they don't have the urge to drink, so it does block that, but they can still be impaired upon driving, operating equipment, whatever. So here's a 54-year-old male using Vivitrol. He was found unresponsive. Well, he was revived, and on urine drug testing, we found out he was drinking and using fentanyl. And in this case, we actually ended up having to do an ETG-ETF. So he had been drinking and then also using fentanyl. Wouldn't have known that without the technology and the testing. It changed the entire course of treatment for this individual. And thankfully, he started doing a lot better. This is an epidemic. that is growing faster than we ever imagined. The cost in lives and money is pushing the envelope of everything the system has to offer. We need a solution now. And that brings us to our questions and answers, and I'm actually surprised that I was able to pull this off before 1:30. Thank you.
Dr. Pomm, thank you so much. This is Leanne again, and we do have a few questions, and if you're ready, I'll go ahead and pose those to you.
Okay.
The first question takes us back to your comments about poppy seeds. And the question is simply, are you talking about poppy seeds that are on muffins?
I'm talking about poppy seeds that are in cake, muffins, whatever, poppy seeds. I'll be honest with you, a poppy seed bagel. It's dramatic how high a morphine level will get on testing after you eat a poppy seed cake or an everything bagel. So, yes.
Okay, and the next question is sort of a comment and then a question. I have seen doctors prescribe benzo and opiates at the same time. Will the patient die?
That's a great question. It's not unusual to see pain doctors prescribe opiates and benzos at the same time. And yes, they have died. They're not. If you're assessing if they're not addicts or alcoholics, and you're prescribing them in a controlled fashion, following them very closely with urine drug screening and pill counts, and you've got a very compliant patient, there might be a case for prescribing both. For muscle relaxant capabilities, there are other medications they can use that won't cause this problem. Unfortunately, so many doctors have prescribed numerous opiates, number of pills, bags of them they come out to be. Pills of both types, they're being used by the individual, they're being abused by the individual, and they're being sold by the individual. Some legislation is coming down the pike where it's going to limit some of that. But it actually, because of tolerance, there's no way to determine how much in the way of, let's say, oxycodone plus how much Xanax is going to cause death. I can just tell you the combination at some point stops people from breathing. Part of it depends on their tolerance to the medications. You throw fentanyl in there, throw the tolerance out the window, and now all of a sudden it doesn't take a lot at all. Of course, hopefully they're not prescribing fentanyl, but they're getting it on the street. And one thing I haven't said, fentanyl is now showing up on marijuana, cocaine, fentanyl. They have pills that look like Xanax that have fentanyl in them. You take that, you're going to die because it's a combination of Xanax and fentanyl. You've got some Percocet-looking pills out there that actually are fentanyl, and people are dying taking those. So, I'm sorry, had to throw that in there.
Dr. Pomm, thank you. And then the last question is, what causes a test to come back negative when you know that the client has been using and they have admitted to it?
Okay. So if we're talking about point-of-care testing, the threshold levels of the testing are much higher than confirmation testing. So you might actually have a testing level of 1,000, I'll give you an example, 1,000 nanograms on amphetamine. Well, they could be using amphetamine. By the time you get the urine, that level has dropped below 1,000. If that level drops below 1,000, it's going to be negative, even though it's in their system. Confirmation testing drops that level, that threshold level, down to 50. So the chances of you missing it, or the chance of you catching it, are far greater. That's the typical reason why with point-of-care testing you have negative results even though you know they're using. The other thing is, as I mentioned, that if you're not specifically testing for the drug that you're looking for, you might get an opiate panel and they're using oxycodone, but you're not testing for oxycodone. They're using methadone, and you're not testing for methadone. That'll also be a negative, as an example.
Dr. Pomm, thank you for addressing those questions. And thank you for joining us today. It was a great presentation, very interesting, and we very much appreciate you sharing your expertise with the broader community. For our participants, I did want to mention a couple of things as we bring the presentation in for a landing. I know everyone's busy. First of all, thank you to everyone for attending the webinar today. Do remember that when you exit the event, when we close it down, your browser is going to take you to an evaluation form on the FATA website. You'll also get a second opportunity if for whatever reason that doesn't work and you don't get to the website evaluation as expected. You're going to get a follow-up email from us a little bit later today, and that will give you another opportunity to complete the evaluation too. So be sure to take care of that. And then in closing, we want to also be sure to thank the Florida Department of Children and Families, Office of Substance Abuse and Mental Health for funding today's presentation. And again, Dr. Pomm, thank you so much. It's been a pleasure working with you and hearing today's information. And for everyone else, have a great rest of your day. Thank you very much.
Thank you.